Mhm. All right, well, welcome to Valley View Hospital University, our Women's Health Series. I think I'm second in the series. And I want to thank you all for spending your lunch with me today to kind of learn a little bit about urology as it applies to women. I just have a few things that we need to talk to you about before we get started in regards to questions at the end of the presentation. You can submit questions throughout the talk through the chat on the bottom of your screen. Your questions will be answered during the presentation at the very end when we'll open it up for that. And we'll try the best we can to answer those in the time that we have and in as regards as it pertains to what we're talking about. And we are unable to answer questions about you personally. So this isn't a personal call, and these are all general questions that we would ask you ask. The whole asking for a friend thing. All right, so let's go ahead and get started because we've got a lot of ground to cover. I thought about what I see most of my female patients for in the clinic, and in truth, there's like three broad topics that I hit most with women, and each of these is worthy of a lecture in and of itself. So I'm going to try to hit the high points without making you feel like you're rushed at all. So in regards to disclaimers, this is only for informational purposes and it shouldn't be used in place of an actual visit with the doctor. You guys all know that. The big three things that I see women for in the clinic are not just urinary tract infections, but recurrent urinary tract infections. Any doctor can treat a UTI, but once you get to a point where you're having them all the time, I think it's great to have a urologist involved. Obviously, urinary incontinence, there's multiple types of that. And the last one is pelvic organ prolapse. If you feel like your bladder is falling out, you might want to see a urologist or a GYN. So in regards to recurrent UTIs or in UTIs in general, we know that we want to talk about like how often it's happening. Are you alone? What are the long-term effects? A lot of my patients get really anxious about what it means for their health if they're having urinary tract infections constantly. We try to rule out any anatomic factors that may be contributing to your risk for UTI. And we also want to let you know what your defense is against an infection and then how we manage them. Urinary tract infections, they're very, very, very common, more than 7 million visits per year. They complicate more than 1 million admissions. So people who are admitted to the hospital for other reasons often have concomitant UTIs. And obviously, they're way more common in women than in men, except for the neonatal period and in advanced age. Prevalence, how many people are affected? Overall, about 3.5%, and that number increases with age in a linear fashion. So the older you are, the more likely you are to have problems with infection. That's 30% of women between the ages of 20 and 40. That is 30 times more than men. And part of that has to do with anatomy. We'll talk a little bit about that. UTIs increase with hospitalization, with institutionalization, which means patients in nursing homes are much more likely to have UTIs, and that's men and women. Immune suppression, and there's a lot of medications that patients take that suppress their immune systems, and also stress affects your immune system, chronic illness, and concurrent disease. So infection breeds infection, and I say that because if you've had one infection, you're at highest risk to get another one in the short period of time after you've been successfully treated, partly because of the bladder mucosa and how it responds to treatment and ongoing inflammation, and partly because you're just you're susceptible to another infection after you have the inflammation that is associated with infection. This is the big thing I want to make sure that we tell patients who have recurrent simple urinary tract infections. This is not with a fever. This is not involving flank pain. This is not involving sepsis. This is just simple cystitis. And there is no association between uncomplicated recurrent urinary tract infections and renal scarring, risk for hypertension, progressive renal failure, all those bad sequelae. Those are all happening in the setting of what we call complicated UTIs, which are generally infections that are associated with anatomic abnormalities or infection, or high fever rather. I would say the bigger concern in terms of long-term effects has to do with antibiotic overutilization and the associated effects that come with their usage. There's a big push nationwide to develop some stewardship around how we manage antibiotics. and antibiotic therapy, especially in patients who are getting multiple courses. A lot of research going into the dogma associated with long-term antibiotic courses, like where is the value in that, and where are the risk-benefit ratio in those longer courses. And so that's why I think a urologist or somebody who treats recurrent UTI should be involved in your care if you're someone who's having more than 3 in a year. Again, I kind of mentioned with the complicated UTIs how it's a different situation, and we have to look for different causation. So anatomy. Women are particularly susceptible to UTIs because of how we are built. We have close proximity of the rectum and the vagina to the urinary tract. I'm going to move forward to, I have this great little slide that kind of shows this. You can see where the, let me see if I can point. I guess I can't really, maybe I can point. Yes, here's the uterus, and here's the bladder and the urethra. Here's the vagina, and here's the rectum. All of these apertures, openings, are along the perineum. So since they're all in close proximity, it's really easy to get UTIs when there is a source of bacteria here potentially, and as well in the rectum. So because we have a close proximity of all these structures together, we are at higher risk. We also have a very short urethral length. And the fact that bacteria kind of start at the opening, kind of work their way up to the top, is a well-established method of pathogenesis. And the bacteria just don't have as far to go in women as they do in men. There's also the changing vaginal environment with changes in hormones, like with menstruation, menopause, medications, all these things, infections, vaginal yeast infections, all these things can change the vaginal environment and change our flora and predispose us to UTIs. Estrogen has a big effect in preventing UTIs, particularly in postmenopausal women. I'm going to kind of go over that here in a second. And also dysfunctional avoiding habits. Women are particularly at risk for dysfunctional avoiding. We're multitaskers, and so we're doing multiple different things, and we're always going to put off that need to void until we really, really, really have to go. So oftentimes we hold it for longer than we should, and that puts us at risk for infection as well. Our lovely drawing again. So what is our biggest defense against the UTI? Peeing is our biggest defense. The flow of urine through the urinary tract and our actual voiding, peeing out the bacteria, are our primary defenses against infection. Becomes a problem for patients who are incontinent, because every incontinent patient stops drinking water because they don't want to leak as much, and so they're not voiding as much, and so that puts them at risk. Also, we're busy, and we also oftentimes don't drink enough fluids throughout the course of the day. We're too busy to pee. This is something we learn as little girls because we don't want to miss out on what's going on, and we become holders. And so this puts us at risk. The low urinary pH and concentration of the urine inhibits bacterial growth, and there's some urinary components that tend to reduce the survival of bacteria, including the minerals and salts and the urea present within the urinary tract. Another big defense is the vaginal flora, the good guys. If we go back to our little drawing here, the vagina is colonized in here with primarily lactobacillus, but other commensal organisms that they're hanging out with us. They live with us. They're the good guys. And because they're there, there's no room for pathogenic strains of bacteria to move in. So that actually protects us from infections, because those aren't going to cause infection of the urinary tract when we're sexually active. As we age, changes in hormone levels decrease the number of lactobacillus in here. Spermaticides can kill lactobacillus, though I don't think many people are using spermaticides much anymore. Sex itself, just the friction of sex can decrease the number of the good guys along the vaginal lining. And in fact, use of antibiotics, of course, strips our vaginal lining as well, puts us at risk for future UTIs, ironically. So those guys we want to keep in good stead, and that's where a lot of our yogurt is helpful during treatment for UTI, because it helps replace a lot of those lactobacillus. And of course, genetic influences. We have certain host resistance factors that help us protect us against UTI, but sometimes we lack them. And so oftentimes I'll see patients whose mother was prone to UTIs, and therefore she is prone to UTIs because she perhaps lacks some of those factors that have been identified at the level of the bladder mucosa or the bladder lining that actually prevent UTI. So who do we want to see? Believe it or not, this is sad, but we don't consider it you to have a problem with recurrent UTIs unless you've had more than 3 infections in a year. Having said that, when you start to have them in clusters, like every month, it seems like you're getting one. If you've had 3 of those, then you should probably be seen by a urologist, because we've got to look at why. We've got to break the cycle of those recurrences so that we can get along with our lives. And when. Again, I'd like to be involved in management when you've been on multiple courses of antibiotics, since we really want to try to mitigate that a little bit. And again, the what. And again, this is probably, we do see a lot of these things in the clinic, but the foreign bodies and the obstruction and the unusual anatomy, those patients are generally much sicker and are being seen in a hospital-based setting rather than in a clinic setting. To recap a little bit, for all women, we want to manage constipation. We already know that the rectum and the anus are a source and a location for bacteria to thrive. I mean, we all have E. coli in our guts. In fact, 80% of patients with recurrent UTIs, it's generally 80% of the time E. coli. So getting rid of stool from your rectum will decrease that high colony count or high amount of bacterial load and decrease our risk for infection. We're going to push hydration. We're going to be peeing. We're going to be pushing urine through the urinary tract and peeing out the bacteria so they can't continue to replicate. If we're sexually active and we're having infections that are associated with sex, like occurring a day or 2 after the fact, then we consider prophylaxis within our course. And there's some antibiotics that we can give that are in a class of their own that are less likely that don't change the fecal or the vaginal flora, so don't set you up for yeast infections or for gut problems. And then we like to educate our patients regarding voiding dysfunction. Again, we start off as little girls as holders. We're prone to it. And so voiding frequently, being kind to our bladder allows them to be kind to us. And then particularly for postmenopausal women, vaginal estrogen, I feel like it's a mainstay. It treats 70% of recurrent UTIs. Every older patient, postmenopausal woman who is prone to urinary tract infections should be on vaginal estrogen. And even if they are, it doesn't mean they will never have another infection, but it definitely decreases the frequency with which the infections occur. And we also consider daily prophylaxis. I can tell you, I think on one hand, the actual names of the patients that I have who are on low dose daily antibiotics therapy, because I consider that an mission or defeat. There's lots of things we can try before we get to that point. All right. So next topic, we're moving on to female urinary incontinence, which again is a major complaint that I evaluate women for in the office. I'm going to define it. We're going to talk about how frequently it occurs. We're going to talk about some risk factors. We're going to talk about how we void and why and where the problems can occur and how that happens. That sets us up for incontinence. We're going to go over a little bit of anatomy again, and we're going to talk about medical management and surgical management. So what is it? I think we all know incontinence is basically an involuntary loss of urine. The reported incidence you can see here is very disparate. 4.5% to 53% of women, oftentimes not well reported because women are embarrassed and they don't want to talk about it, or they feel somehow that this is just the price you pay for having children. There's sometimes a stigma attached to it. Women sometimes the problem happens gradually over time and they just kind of accommodate to the problem. One year they're using 1 pad a day, and then 5 years later it's up to 3 or 4, and they kind of don't even notice the change happening. And many suffer in silence. I think that's really sad, because there's definitely a conversation to be had about incontinence, all different types. And on that note, how we classify it, I like to look at it as stress incontinence versus urge incontinence. And of course, there's people who have a mixed pattern. But another way to look at it is, are there bladder problems or are you having sphincter problems? And the stress-related incontinence is leakage that you get with coughing, sneezing, laughing, exercise, really common or more common in younger women. Even women who've never had a child or women who have had cesarean deliveries can be at risk for leakage in this because of this issue. And then, of course, the urge-related, or the so-called overactive bladder. I have a whole couple slides on that particular issue, because a lot of women come in, with that type of leakage and think that they need a sling. But slings only help stress-related incontinence, only help leakage with coughing, sneezing, laughing, exercise. They do not help patients who have urge-related symptoms. So what are our risk factors? Certainly there are predisposing risk factors. Our genetics, our tissue quality, there are certain collagen subtypes that don't age well, basically, and aren't as supportive as we age. And then if we add children onto that, delivering children, and lifestyle, like uh, patients who lift a lot of heavy weights, like my athletes, or patients who are ranching families who are shucking hay and pulling oats for animals, and they're lifting constantly. That'll put you at risk for incontinence. And of course, there are the anatomic and the neurologic factors. The anatomic stuff is generally altered by deliveries. The neurologic factors, we can get MS, we can get Sjogren's syndrome, we can get all kinds of other problems that set us up for incontinence. But there's the promoting things. So these are the things that we generally have a little bit more control over. Obesity, poor nutrition, smokers, high activity levels or low activity levels can put you at risk for incontinence. Toilet habits, again, this is the whole concept of dysfunctional voiding. Like, are you a holder? How much fluid we're drinking, and of course medications. There's a lot of patients who are on diuretics for cardiac disorders, for blood pressure concerns, and they'll make you pee quite often, and it puts you at risk for leakage if you're not able to get to the restroom in a timely fashion. And then, of course, there are the decompensating factors like aging. As we age, we're at higher risk for incontinence. Again, medications put us at risk for this. And then physical and mental well-being. While Parkinson's and Alzheimer's don't necessarily cause incontinence, they can certainly make underlying problems with incontinence significantly worse. Additional risk factors, vaginal deliveries, but particularly in the younger women, it causes a partial denervation, or a neuropraxia is what we call that, of the pelvic floor in a majority of women delivering their first child, majority. And the patients who are at highest risk have a long second stage of labor, which means the pushing phase, or in the patients who have larger babies. Anything statistically over 7.5 pounds, or any children born at greater than 7.5 pounds, are giving their mothers a higher risk for urinary incontinence. And then estrogen deficiency, which leads to atrophy of the spongy tissue that supports the urethra. And so as that tissue thins, it causes a flattening of the urethral epithelium, and then we don't have that same ability to coapt our urethra. So any cough, sneeze, or laugh, that pressure, that increased pressure onto our bladder is not able to be compensated for by the urethra, and then we have an episode of leakage. So kind of more in detail about some of that. This is just kind of how it all goes down. I like to break it down into bladder causes of incontinence, where we're thinking about detrusor overactivity, fancy words for meaning bladder spasms, basically, where your bladder has these abrupt contractions that can cause this profound urge to go, and then sometimes it overwhelms a patient's ability to hold it, or their bladder's already full. A lot of times they'll go ahead and leak. There's a phenomenon called low compliance, which basically is a stiffness of the bladder, and patients with this particular problem aren't able to hold a lot of urine, and they'll feel that urge early because the pressures start to go up. And there's, of course, decreased capacities, the pee bladder, the patients who are peeing constantly. Over time, if you're peeing all the time, low volumes, your bladder it's kind of like your stomach. After you've been ill for a while and you can't eat a lot, and you go back to eating after you feel good, and your stomach just can't hold a lot. Same thing with the bladder. If you're constantly emptying your bladder, constantly peeing, and small volumes, you'll never get to the point where your bladder can hold more. So those are all reasons why patients can get incontinence that are as a result of the bladder. And then, of course, the sphincter, which is, again, where slings come in. One of my pet peeves about slings is people come to the surgery like, I'm having my bladder sling, but it's not your bladder. The problem is the urethra. It's the supportive structure of the urethra. I've got my fancy little picture looking at anatomy here shortly that will kind of go over where a sling would go underneath the urethra, not actually involving the bladder at all. So again, for the sphincter, we have functional problems like that failure to coapt, like we were talking about with menopause, declining estrogen levels. That's what atrophy is. Histories of radiation. Radiation causes changes to the tissue that doesn't allow it to work the way it did before. Sexual abuse and neurologic conditions like multiple sclerosis. These things cause pelvic floor dysfunction and an inability to retain your urine. Anatomically, the urethra lies in a position where it can be compressed against the fascial layer on which the bladder and the bladder neck rest. So when you lose support with atrophy or after having children, then you don't get that same compression. So you have what I call instability of the urethra. So if we can, the sling would go underneath that, provide stability underneath it so that you no longer yawn open when you cough, sneeze, or laugh. Prolapse can set you up for that because of the changes in anatomy that pull the urethra open and no longer provide that compression up against that fascial layer. So in terms of management, for surgical management, and this is again for patients who have stress incontinence, that's leakage of coughing, sneezing, laughing, and exercise. We can do urethral bulking agents in the patients who have a failure to coapt. Like those are the patients that we do an exam and I have you cough and I can see you leak. If urine is just coming out with the slightest increase in abdominal pressure, especially when you're in a supine position versus in a with gravity assisting, then we know that you have an issue, and a urethral bulking agent can be really helpful. That's a quick outpatient procedure without any downtime where you're better the next day. That's a pretty remarkable improvement with such a small thing for what is a big problem for a lot of women. And so slings as well, I've kind of been hitting on that and who would be a candidate for that and what that particularly addresses. And for the medical stuff, how we manage this is medication rather. There's a variety of medications out there. In general, I'm not a huge fan of them, though they can be quite effective. I look at them as Band-Aids. Rarely do they treat the underlying problem. They're managing the symptoms. So we always try to look at causation, like why are you having this problem with overactivity, which is the medical part of this. Pelvic floor physical therapy has exploded in the last 10 years. When I first came here 22 years ago, there were no physical therapists here who did pelvic floor. And now I think we've got 8 on staff here at Rocky Hospital in all different locations. So that is a real mainstay for managing the pelvic floor dysfunction we see that can contribute to urinary incontinence. And of course, behavioral modification. I think people always, I don't know, I think it's sort of underrated how important behavioral modification can be, because we have to think about it, right? You have to maybe do some timed voids. You have to do some Kegels. We have to kind of strengthen our pelvic floor, core exercises, fluid restrictions after certain hours. These types of things can be highly effective in preventing unexpected leakage. Just a few slides on the overactive bladder, because this is the term used to describe, which, on urodynamics, which is a functional bladder test we run on some patients, where we can actually see increases in bladder pressure as the bladder goes through its filling phase. And so when you can actually identify that, on urodynamics, then we know we've got something to treat. But it's difficult to assess its true prevalence. A lot of women, especially with age, have some degree of an overactive bladder, and we accommodate a great deal to it because the changes happen so slowly over time. Rarely do we truly find an etiology. I mean, occasionally with multiple sclerosis or with patients who have, again, pelvic floor dysfunction or rectal spasms that are contributing to overactivity in the bladder, we can point to a cause, but it's not going to change how we manage the patient because we still have to address the symptoms. A cure is rarely achieved, but having said that, I recommend to any woman who's having issues with any of this to come in, because what I tell patients is that we may not be able to make you perfect, but we can probably definitely improve your quality of life and your symptoms and your degree of leakage. We can almost always make things better. And of course, the biggest risk factors for this are normal aging, outlet obstruction, that can be from prolapse or from really for prolapse primarily for women, and then neurological diseases. And the multiple sclerosis is the biggest one we see out here. Spinal cord injury can be a problem too. For the men, it's really outlet as the bigger issue. And so how do we manage this? Again, like I mentioned, the goal is primarily to rebalance your lower urinary tract function to prevent episodes of involuntary spasms and incontinence. We want to manage your symptoms of urgency and frequency. And really the cornerstones of therapy are behavioral modification and medication. Or with behavioral modification alone, you can have a 70% improvement in your in the number of leakage episodes that you have. And if you add medication on top of that, it can approach 90% improvement. And then the big one is neuromodulation. InterStim, which is a basically like I call it a pacemaker for your bladder. It has been something that's been around for a number of decades, but in the last 10 years, it's really become much more mainstream. Which are the patients who benefit from it? How do we place it? How do we control the settings? And Dr. Castle, who joined us 2.5 years ago, maybe it's 2 years ago, but he is very well versed in this particular treatment, and some patients benefit a great deal from that neuromodulation. We also have some in-office neuromodulation we offer, posterior tubular nerve stimulation, which is an acupuncture-based treatment. Again, if you come in and you have this problem, we would go over all of your different options with you. So behavioral modification. We want to understand our basic bladder physiology, which is that there is a central nervous system involvement in how our bladder behaves, so that is under skeletal control. So we have voluntary control over the on-off switch that is linking our bladder and our brain. If that gets disrupted in any way, then we start to have problems with how we void. Again, sexual abuse for my younger patients tends to be a really big problem because it impacts your pelvic floor and causes hypertonicity or really a tight tone, or you can have a really loose tone in your pelvic floor that can actually change what the kind of bladder sensations that you get, and you become a dysfunctional voider. We do a lot of dietary and fluid management, and part of how we figure that all out is with a voiding diary. And this is something, you don't need a doctor to walk you through this. This is actually something you could do on your own to see if there's particular triggers to your symptoms. And we do timed voids. I talk to a lot of my patients, especially if they have mobility issues, about going to the restroom every 2 to 3 hours, even if you don't feel like you have to go, to try to preempt that urge before it hits you and you have no time to get there. And again, pelvic floor therapy can really be helpful in depressing the spasticity involved with the pelvic floor musculature, which then kind of transmits itself to the bladder as a kind of a passive bystander and cause significant issues in the bladder. But ultimately, the success is dependent on compliance. Behavioral modification is 100% on the patient. We can guide you through it, but any kind of physical therapy is 100% on the patient. Physical therapists guide us through it, but ultimately we have to be diligent about consistency and actually doing the exercises on a regular basis, doing our homework, basically. So my final topic, or the final issue that's the top of the top 3 for which I see women for in clinic, is that is pelvic floor prolapse. When you feel like something is falling out of your vagina, a very unpleasant feeling. Much like incontinence, much like all of these concerns, it's difficult to assess because a lot of people don't actually admit that they're having that particular problem, or they accommodate to it. The incidence is much greater if hysterectomy was performed for prolapse. And in fact, the incidence is greater if you've had a hysterectomy at all, because the uterus is a very important organ of pelvic floor support. And once you no longer have it, your other organs in your pelvis, your rectum and your bladder, even additional bowel can drop through and cause a prolapse. The lifetime risk for all comers is about 11%. The reapparition rate is high, especially now that we've moved away from the era of mesh. Mesh got interesting about 10, 12 years ago because there is a significant failure rate for a lot of these repairs, because weak tissue to weak tissue, when you're repairing a prolapse like this, is still weak tissue ultimately. And we want to live our lives. We want to be active. So that puts more pressure on our pelvis, and we're at risk for failure. The risk for prolapse doubles with each decade of life. So the older we get, the more we have issues with this. And primarily that's because of tissue, and not just tissue, but also tissue changes. The pelvic floor thins and atrophies with age, just as every other muscle in our body atrophies with age. So we're at higher risk. And then of course we add all the insults that we have throughout our lifetime, like children and what we do in our day-to-day that puts us at risk for prolapse. And over the years, and again, since I've been doing this for the last 22 years, there have been cycling theories on the best surgical management for how to deal with this problem. When I first came out, it was the standard application repairs, a vaginal approach. Then we started doing abdominal approaches, where we were taking a piece of cadaveric fascia and pulling up the vaginal cuff and tacking it to the sacrum. And then the robot got involved with that. And then we've kind of moved back to vaginal approaches as we've compared and contrasted how well each of these approaches work and in which patients are best served by them. And so, you know, you may get more than one opinion when you talk to somebody about what's best to do. So what are our risk factors? Again, it's a lot of the same stuff that we deal with for incontinence. Aging puts us at risk for this, menopause, pregnancy, obesity, previous hysterectomy, kind of all the stuff we've been talking about. Constipation, if you're always straining to have a bowel movement, you're going to be putting a lot of pressure on your pelvis and you're at risk to prolapse. Chronic respiratory disorders, coughers. People who are coughing a lot are at much higher risk for prolapse. Smokers, smoking consistently impacts your tissue quality and it puts you at risk for coughing and you can have you're at higher risk for prolapse. Of course, the exercisers, the CrossFitters, the ranchers, these people are at higher risk for prolapse. And of course, our basic tissue integrity. So again, I love this picture. I have a model in my office similar to this. It kind of gives you an idea, you know, of what we're doing or what we're of what should be normal and why we run into problems when it's not. For my patients with stress incontinence, this is where a sling goes, right up underneath the urethra. It's not a bladder issue at all. This is just a sling. We're supporting the urethra. There's a lot of variation between the length of the urethra in a woman. It can be anywhere from 1 to 3 centimeters. And so the women who have shorter urethras are more prone to coaptation issues. I show this to you now for the prolapse part of this, though, because I want to show you because we look at pelvic floor prolapse in terms of compartments. Like the anterior compartment is the compartment where the bladder is. This is the middle compartment, and then posterior compartment is where the rectum is. A lot of women who have a uterus removed, their uterus is out, they have run the risk of having their bowel, because there's all the small bowel up in here that can slip down and through here and then bulge out this way when you don't have a uterus to block it. So all kinds of, you know, fun things happening when you have basically a potential space, which is what the vagina is. So the presentation can be really varied. I mean, again, I think most patients who have surgical prolapse are coming in with a bulge. They feel like they're sitting on a tennis ball. They have trouble emptying their bladder because of kinking. We come back to here. If you think about the bladder on a hinge here, with a hinge right here, the bladder prolapses. It's basically dropping into the vagina here and showing up outside. And as you can see, the urethra stays relatively stable and then basically gets kinked. And so patients have trouble peeing. That can also cause urinary incontinence because of overflow. Like then all of a sudden you kind of change position or you move up like this and all of a sudden the urine just kind of comes out. And of course, discomfort with intercourse, if there's something else in the vagina and you're trying to put a penis in there, that could be uncomfortable. The smaller prolapses that aren't necessarily as dramatic or pronounced can present with a lot of voiding dysfunction, frequency, urgency complaints, again, the incontinence issue. This middle compartment, about 40% of the patients I take to the OR to repair a bladder prolapse or a rectal prolapse will end up having what we call an enterocele. And if we go back to my fancy little picture, that's again because generally the uterus is gone and we've got bowel that's either slipping down this way or from up in here and slipping down in here. So that's the middle compartment. A lot of times that is not necessarily observable on an exam in the office, but when you're in the OR, it's pretty obvious. The posterior compartment, these are patients who have difficulties with bowel movements, like they're having to use a hand in the vagina, pushing here to push stool out, or they're having to use actually a finger up their rectum to because it kind of gets trapped. Again, if you think about the rectum prolapse into the vagina, it comes this way, and so stool can get trapped in the vagina, so they have to use a finger to pull it out. And I think women who are doing either of those two things should consider having a correction when we think about how these procedures go in the OR, how generally well tolerated they are, how quick they are, and how relatively, I mean, insofar as surgery goes, they're not terribly uncomfortable. And honestly, I will tell you that most patients who have a significant amount of prolapse on exam, I'll ask them if they're having to do those things, because women rarely kind of offer up that information. You know, they have to do that to have a bowel movement. Again, there's that whole idea of stigma that's so gross. Every time I have a bowel movement, I have to stick my hand in my vagina or stick my finger up my bottom. So it's worth fixing, it's worth correcting if it's an issue. And having said all of that, Lots of women have prolapse. Like any woman who's had a baby will have some degree of pelvic floor prolapse. We only fix it if it's causing a problem. If it's not causing you any problems, then there's no need to do anything about it. No one dies from prolapse. Again, when to treat, it's when you have symptoms, when you're bothered enough to consider treatment. Age and activity level. You know, the older you are, the less or the more sedentary you are, you may be less inclined to pursue any sort of intervention because you're not terribly bothered. It's not something you're thinking about on a daily basis. We use conservative approaches for malprolapse because most women who've had babies have some degree of laxity there. And then we have to think about your history of previous surgery. Patients who have previous prolapse repairs are at higher risk to fail on a subsequent one. Occasionally we'll do urodynamics, which is again that fancy functional bladder test that we run to kind of get an idea of how much urine your bladder can hold, whether or not you're having those bladder spasms or that overactivity that we can actually measure. What your leak point pressures are, like are you leaking with a low pressure? These kinds of things give us good information to determine whether or not you're going to benefit from any kind of surgical correction. And again, the quality of life situation. How bothered are you to consider doing anything? So our options for management are to treat the symptoms. We can treat your frequency, your urgency feelings. We can do pelvic floor therapy to kind of increase the tone in your pelvis so you feel less of that prolapse. I can't tell you how many patients I've put on vaginal estrogen, and all of a sudden when the tissue is not so dry and it's not, you don't get that chafing feeling, you're much more comfortable with prolapse and you say, hey, I don't really need surgery. Stool softeners, managing constipation is really important too, because the more constipated you are, the more likely you are to push, exacerbate your underlying prolapse, be more symptomatic from it. We do pessaries, which is a device that, mechanical device that actually holds up the bladder or the rectum by being in the vagina. And they're ideal for the very elderly and the less active, or for patients who are poor surgical candidates, because they're not terribly comfortable, and there's a lot of hassle with them in terms of you have to change them out monthly to clean it and put it back in. You can be associated with infections. It doesn't allow for good estrogen support when you have something else in there. Again, I will always mention a pessary to patients because it is a conservative non-surgical management, but I think for my younger patients, and by younger I mean 40s to 60s and older, if you're very active, pessaries aren't ideal. There are a variety of surgical approaches, something I alluded to earlier. The traditional plication repairs, which we do here, and they're very successful. Robotic sacrocolpopexy, this is super fancy and sexy. It can be very effective and can address multiple compartments at a time. Mesh is often involved in this. And the other one that's kind of like old school, but is really coming back, is colpoplysis, which is basically a defunctionalization of the vagina, where we close off the vagina at the level of the hymen ring. If I go back to my one little picture, see if I can do that. Well, that's gonna be too complicated. But if we go back to the picture, it basically kind of walls off the vagina at that location, so nothing can prolapse beyond it. Very low failure rates, very well tolerated. We can in fact do it under local. So even the poor surgical candidates are oftentimes a candidate for a colpoplysis. The caveat with that one is, of course, you can never have intercourse. I always make sure to tell my patients that there's more than one way to have sex. It's still orgasm. We talk about all of that when we talk about this as an option. So that's what I got for you guys. I'm happy to entertain questions at this moment. I welcome them. I think my question person's coming.
Is there any possibility of a vaccine for recurrent urinary tract infections?
That's a great question. With the this question is there any possibility of a vaccine for recurrent urinary tract infections? I do know they are doing work on this, but I don't think there's nothing that's available mainstream or that's super successful and available mainstream just yet. I will be at a conference next month, and I'm sure that will be addressed then. There is, what's a bummer is that historically, and this was actually like 8-10 years ago, they were looking at using fecal transplant for patients who've had for recurrent UTIs with a lot of success. but they really never could get significant traction with it. And there are some risks with fecal transplant. And so it kind of fell by the wayside, though I do believe research is still ongoing in this area. And I would love that to happen because I have some patients who are just miserable. And I think until we are actually able to do something like that, where we are able to prevent the future. I mean, I had one patient who gave herself a fecal transplant, and she's still doing great. I know exactly that one was saying, because I mean, that's badass. But I think we've got, there's other thoughts too about why patients are prone to recurrence, and one of those would be the biofilm idea, which again, really hard to diagnose, and no one has any idea how to eradicate that. Yeah.
You talk about the couple of components of this question. The best form of estrogen, tablet versus cream. And then if you're trying to do something such as periurethral application, how do you know you're getting it in the right place?
Okay. So the question was, which is the best form of vaginal estrogen replacement? And how do you know if you're getting in the right place? Right. I have a bias. I hate vaginal estrogen suppositories. I loved them when I first came out of residency because the doses were appropriate. Now they've dropped the dose way down, and so I don't think they're actually effective. I can't tell you how many patients I've switched from a vaginal estrogen suppository to a cream who then now do better in regards to treating their frequency and urgency, and also to preventing UTI. So I'm not a fan of the vaginal suppositories, though a lot of patients are because they're not messy, but they're also really expensive and they just don't work as well as the creams. I love estrogen rings, super expensive also, and really hard to get. We were sending patients to Canada to get them, and now you can't even get them from Canada. Medicare doesn't cover them, which is ridiculous, but they'll cover your hospital admission for sepsis. So I have a problem with that because it's such a simple thing, but they're really, really expensive. What's weird is that 10 years ago, I was prescribing them to patients, 15 years ago, prescribing them to patients. I thought they were expensive at $220. Now they're pushing $800. We should be generic by now, I think, but not a burning issue for those who are in charge of determining price.
Solifenacin, anticholinergics. Is there a problem with taking it long term?
So long-term usage of anticholinergics or drugs that treat overactive bladders. I would tell you that first of all, for a lot of those drugs, you develop tolerance. So over time, they just don't work as well as they used to. The other problem with those is that as you age, you're at higher risk for cognitive impairments with the drugs because they cross the brain-bladder barrier and the brain-blood barrier rather, and they can cause just confusion, fuzziness, slowness. So a lot of patients as they age, like honestly, there's a whole list of drugs called the Beers classification, and all anticholinergics are on it. In other words, not recommended for patients over the age of 75. So again, as I mentioned in the talk, those drugs are helpful. I think they're Band-Aids. I like to use them for short term. I use them as crutches sometimes, but I don't think they're in many cases treating the underlying problem. They're treating the symptoms. And again, it's always a conversation you have with patients about, do you feel like you're getting a benefit from this to continue its use? There's a new class too that's come out in the last 5-6 years, unfortunately very expensive, but that don't have any of the cognitive problems, but Medicare oftentimes will cover them for the older patients, which is a bummer.
Aside from pelvic floor physical therapy, when it comes to overactive bladder, any other exercises, yoga, Pilates, that's helpful? So
the question is, aside from pelvic floor therapy, is there any other kind of exercise or behavioral thing that you can do that can prevent or can improve urinary incontinence? And I would tell you, yes, 100%. Anything you do that strengthens your core will aid in treating urinary incontinence. And I know this from personal experience because I was a CrossFitter and I was there and everyone's like, oh my God, I want to do jump ropes because I'm leaking all the time. Like, well, this could be great. I want to meet all these people. They're going to need surgery. But after 8 weeks, they're like better. And so that was great for me to see that yes, I can see that you actually, as your core gets stronger, you'll be less likely to have problems with leakage.
Okay. You somewhat address this, but can you go back to why does sex itself lead to urinary tract infection?
Why does sex itself lead to urinary tract infections? Let me see if I can go back to can I go back to that little picture? How do I do that? There we go. Can they see that? Okay, yes, it looks freezing. Okay, so I like to show you this again, this picture, because I think seeing is believing. Me gesticulating is probably not as helpful. So the vagina is right here. So when you have sex, basically you are kind of stirring up all of the organisms that live along our perineum. Again, with constipation, I mean, all of us are colonized with E. coli. People get really anxious about that because of all the GI or E. coli events, like people getting really sick from that, but this is a different type of E. coli. And so having sex, it basically stirs everything up. And because this is just right here, we're at higher risk for urinary tract infections. That was the urinary tract infection sex, right? Not every woman has problems with sex causing UTI, but many of them do. And we always ask patients when they're coming in for recurrent infections, do you feel like they're associated with intercourse, like a day or two later, are you having them? And that's just because your colony counts get to a point where they're finally causing symptoms, because it can take a while. Again, like I mentioned, we know that this ascending approach of bacteria going up the urethra is a well-documented mode of pathogenesis.
You mentioned chronic or long-term antibiotic use having a slightly lower or a lower risk of affecting the gut flora or causing other immune disturbances. Why is that?
No, I think there was a misunderstanding. The question is why long-term courses of antibiotics can be less likely to cause vaginal and GI. I was actually talking about a particular class of antibiotics that we use for prophylaxis. There's one that is not bactericidal, which is kill on contact. It's one that's bacteriostatic. So it does not actually affect the vaginal or the fecal flora. So those are the ones we try to use when we're talking about longer term prophylaxis for patients, because we don't want to have them on something, a big gun, or even a low dose big gun, because even low doses of antibiotics can alter your colonic flora.
Please describe what's involved in pelvic floor physical therapy.
Oh, wow. Okay. So pelvic floor physical therapy, the question is what's involved in that process. I always tell patients this is a very intimate relationship with a therapist. Physical therapists who do pelvic floor therapy specialize in that, but they're first and foremost physical therapists. So when you come in to see them, they are going to do an assessment of you. They're looking at your gait, your abduction, your range of motion. Where are you stiff, tight, hypertonic? Where are your muscles tight in your pelvic floor, and how can we help loosen that up? Eventually, depending on your progress and your initial assessment, they may do some internal work where they're pressing on the levator muscles. Again, if we come back to my little model here, which doesn't really show that, but there's a whole, kind of like if you think about the pelvis like a bowl, there's a whole layer, all these layers of muscle that kind of support all your pelvic structures. They're working on those muscles to get them to relax in a situation of hypertonicity and to get them to tighten up in patients who are hypotonic, who have no ability to engage those muscles. So it's a process, and it is an intimate relationship with a therapist. It's not just like going in to get your artwork done.
With the anatomical chart, please show where the estrogen is supposed to be placed.
Okay, so with the anatomical chart, which we fortunately have up here, the estrogen is supposed to go into the vagina, right? A lot of times patients just put it on the outside, which can help with penetration with intercourse, but doesn't really help with preventing UTIs or treating urgency and frequency. When we're putting the vaginal estrogen up here, we want to make sure that it hits the back wall of the bladder so it soaks through and hits all these estrogen receptors that we know are present in the bladder. With the loss of estrogen with menopause, we lose a lot of the tissue elasticity because we have declining levels of estrogen, of elastin and collagen in there. So just a lubricant oftentimes for painful intercourse isn't enough because you still have that stiffness of the tissue. You really need estrogen to kind of cause or to give you some pliability, some stretchability.
Do you recommend any dietary supplements for UTI? D-mannose, probiotics, vaginal probiotics?
So supplement usage for prevention of UTI. Many are recommended. Very few have a lot of scientific basis or evidence to prove that they're beneficial. D-mannose actually does have some proven efficacy in head-to-head trials with patients who are prone to UTI. It performed as well as low-dose antibiotics in several studies. Having said that, not all patients have that particular abnormality. So, one of the reasons why we think that D-mannose works is because some patients are deficient in the mannose side chain of the cells that line the bladder. And again, like I mentioned, the host, there's like genetic factors that predispose you to infection. There are particular women who don't have that mannose side chain. It's just really hard to, I don't think we've developed any assays to determine which those patients are. It'd be great if we could like do a bladder biopsy, send that and say, oh yeah, you lack this mannose side chain. D-mannose is really gonna be helpful for you. So it's one of those things that, especially since it's not a regulated, it's a supplement, so it's not regulated. I think a lot of women are just kind of on your own. You try it. If you think it works, I have plenty of patients who think it works. Lots of patients who are on it and still having issues. So it's not, unfortunately, a panacea. In terms of vaginal probiotics, they're always great if you've been treated for a yeast infection, if you've been on antibiotics. Again, with supplements, so little study goes into it. I mean, there is some, and there's some cranberry studies now that are emerging, different forms of cranberry that can actually be helpful in preventing UTI. But historically, the studies were all equivocal, which means that some showed it helped, some showed it didn't. I have patients who swear by it. I have patients who say nothing works. Honestly, I don't think it can hurt you. So you just have to try it and see if it helps.
Probably our last question that we have time for. Have you heard of the perfect Kegel exercises? Do you have any?
I have not, but if you see a physical therapist, you can ask them. They may know more about that.
Okay, one more then.
Oh, I'm sorry, this is a particular type of Kegel exercise that somebody asked about that I don't know anything about it.
So back to the specific products, someone has used Allura.
Okay.
What do you think about it?
So someone is asking about a supplement called Allura, and this is actually a concentrated cranberry component that in pediatric trials has been proven to be as good as low-dose antibiotic for preventing UTI. They're doing studies now in adult women to see if it's going to be helpful, but we don't have evidence. We have been using it in our practice, my nurse practitioner and I definitely have some patients who benefit from it. But again, it's not a panacea. Not everyone gets the same benefit from something like that. And again, it's not just a supplement. It's not just adding something you don't have. It's a lot of all the behavioral stuff. It's making sure you have adequate estrogen levels, that you're not, that you haven't been stripped by all the antibiotics you've been taking. There's other factors to why you're managing your constipation, those kinds of things.
That is it for questions.
All right, that's it for questions. We would love to hear feedback from you guys about what you thought about this presentation. If you have the time to fill out a quick survey, please do so. If you don't want to be bothered, don't bother. You'll receive an email with a recording of this webinar within the next 24 hours. Cool. And then our next talk is next Thursday. Nope, the 6th, 2 weeks from now. 2 weeks from now, with Katrina Metcalf. She's a nurse practitioner who's discussing heart health for women. Thank you so much. You guys have a great day.